Bismillah ar-Rahman ar-Rahim. Mr. Chairman, dear colleagues, thank you for the invitation. It's my honor to be here today. And my case is about acute inferior myocardial infarction. It's a simple primary case. 60-year-old male, hypertensive, presented with typical chest pain 1 hour before admission to hospital. Blood pressure 130/70, heart rate 110, and the patient was distressed due to severe chest pain. However, no congestion was available and function was good. ECG shows acute inferior myocardial infarction, and decision was made to do primary intervention. Actually, the left system circumflex was okay, and the LED, there was a lesion here that will appear better in the next view. Here's this lesion in the proximal LED. However, the remaining left system was okay. And right coronary was total, included from its origin, near its origin. So here, the decision to do PCI to RCA or PCI to RCA and LED. And I would like to discuss this point more clearly. According to the American guidelines, it's recommended to do PCI to the culprit lesion only, unless the patient is hemodynamically compromised, and this is repeatedly written in different papers, like in the JACC here, and this is the APEX AMI in the European Heart Journal here. So the decision was to make PCI to RCA, the culprit vessel only. And BMW wire was used with guiding right. As you see here, there's filling defect at the site of the occlusion, just passing of the wire showing this appearance. So we used Diver C aspiration thrombectomy. And with much improvement of the thrombus burden here. So decision was made to do PCI, now stenting with 4/20 stent. And stent is adequately deployed, but there was TEMI2 flow, nearly TEMI2 flow. No reflow appeared here in some thrombus dislodgement distally, although the appearance that seems good after Diver C. At this stage, the patient's chest pain decreased, but however, we developed repetitive stormy VTAC, about 10 times repeatedly, with recurrent DC shock, short periods of CPR, and the patient returned back again without, and came back conscious. So we stopped PCR and try to see again what's going on to the right coronary, the same appearance. So we do intracoronary epipeptide, and the improvement in the right coronary actually improves. So we saw this may be arrhythmia due to ischemia, so loading IV cordarone and then xylocaine to be as ischemic origin of the arrhythmia, but failed to stop the storm. We stayed in this storm for about 5 minutes before we shift the decision to make PCI to the LED lesion. Actually, the patient going into arrest and giving us just 30 or 40 seconds conscious without VTAC, and then starting the VTAC again. So you will find here the PCI was done in a very strange situation in PA view, and actually the patient, no CPR is present because we work only in the 30 seconds in between each VTAC and another one. I'm sorry for the slow movie, but it's not like this. And the wire was entering into the diagonal, but actually there was no time because the patient didn't give us more time to adjust the wiring position. And here we put the stent in the proximal LED with adequate position, thanks to God for this. Immediately after PCI to LED, the storm stopped and the patient was chest pain free. He stayed conscious okay for about 3 days in CCU with a stable course, and discharged home safely with near normal echo and ECG. Take home message: primary PCI is never simple until the patient goes back home, and no reflow is a nightmare that should be prevented by all possible means. PCI to non-culprit lesion in primary PCI is indicated when patients are hemodynamically compromised. And thank you for your attention.